Hello everybody, a warm welcome here to Paris, which has been very stormy today. Today we have a webinar on how to identify patients for tricuspid interventions. And this is organized by the PCR Tricuspid Focus Group. The learning objectives for today are the following. We want to discuss the clinical presentation and medical therapy of patients with tricuspid regurgitation. Second, we will discuss the essentials and the pitfalls of tricuspid valve imaging and quantification of tricuspid regurgitation and tricuspid insufficiency. And finally, we will discuss the integration of hemodynamic assessment, the indications, but also the interventional treatment options which we do have for our patients. Today we have a very esteemed faculty here, partly online, as you will see in a second. With me is Peter Lüdecke from Essen, who is co-chairing with me this webinar today. Then Mariana Adamo from Italy, she's joining us from online, actually from Lyon, because her flight didn't make it to Paris due to the Atlantic storm. And then you see Nicole Karam from Paris and Nina Wunderlich, also from Germany, who's supporting us here today in our discussion. We're going to start the entire webinar with a small patient video, which we think explains very nicely how the patient is feeling and perhaps also what we can offer to our patients.
Mein Name ist Max Kühnhauser. Ich werde 83 Jahre alt in diesem Jahr. Ich bin also fast jeden Tag, auch bei Regen, unterwegs. Ich bin vom Beruf Sportlehrer und fühle mich also in dieser Männergymnastikgruppe verdammt wohl.
Wir treffen uns jede Woche am Dienstag in dieser Sporthalle hier. Dann machen wir ein Aufwärmtraining und anschließend wird also unterschiedlich mit verschiedenen Sachen gearbeitet.
Mein ganzes Leben ist Sport. Ein Sportler zeigt halt immer, dass es geht. Und das ist eigentlich falsch gewesen von mir.
Teilweise konnte er nicht mehr gut mitmachen. Er hat also Probleme gehabt mit dem Schnaufen. Er hat dann natürlich ausgesetzt.
Ich bin da quasi zusammengebrochen einmal. Mir ist es schwindelig geworden. 5 Stufen und musste anhalten, um Atem zu holen. Ich war also voll am Ende. Für mich ist eine Welt zusammengebrochen. Ich war also in ganz desolatem Zustand. Ich konnte nicht mehr schlafen, ich war müde, ich hatte Schwindelgefühle. Also die ganze Lebenslust war verloren.
Die Tricuspidalklappeninsuffizienz ist eine Undichtigkeit der Herzklappe im rechten Herzen. Die fehlende Belastbarkeit bei den Herzklappenfehlern zeichnet sich zum Beispiel dadurch aus, dass man seine Alltagsbeschäftigung nicht mehr in dem Maße nachverfolgen kann. Die Tricuspidalklappe galt bis vor wenigen Monaten oder wenigen Jahren als die vergessene Klappe, deswegen, weil die operative Therapie der Tricuspidalklappeninsuffizienz mit einem sehr, sehr hohen Operationsrisiko verbunden war.
Ich bin dann zu meinem Kardiologen und er sagte, ja, jetzt geht nur noch eins. Entweder Sie lassen sich aufschneiden oder aber ich habe ein neues, modernes OP-Verfahren.
Der Herr Kühnhauser war mit seinen 82 Jahren ein Patient, der zusätzlich zu seiner Tricuspidalklappeninsuffizienz eine koronare Herzerkrankung bereits aufgewiesen hat. Aus diesem Grund haben wir uns dann für ein Katheterverfahren entschieden. Das Pascal wird über den Katheter über die Leiste eingeführt und dann im rechten Herzen so ausgerichtet, dass das Pascal-System 2 der 3 Herzklappensegel miteinander adaptieren kann.
Ich war also sehr erleichtert über diese neue moderne OP Ich muss dahin, trotz Corona, weil ich war am Ende.
In der Covid-Pandemie sind deutlich weniger Patienten zu uns gekommen. Die Patienten, die wir aber in dieser Zeit behandelt haben, sind eigentlich mit dem genau gleich guten Ergebnis aus der Klinik wieder gegangen.
Ich war richtig überrascht. Nach der OP ging es mir sehr, sehr gut. Ich bin auch selbst nach Hause gefahren, von München daher. Ich glaube so 165 Kilometer. Dann am zweiten, dritten, vierten Tag schon schön langsam Treppen wieder gestiegen. Es war wunderbar. Ich wollte ja testen, ob mein Atem dementsprechend wieder vorhanden ist und war glücklich und zufrieden darüber. Und habe mich dann von Tag zu Tag gesteigert. Hin, her und ganz herum.
Ich freue mich, dass die Behandlung bei Herrn Kühnenhauser so gut funktioniert hat und angeschlagen hat, sodass er jetzt weiterhin seinem Sport nachgehen kann und viele seiner Mitmenschen mit seinem Sportunterricht begeistert, sodass er jetzt hoffentlich noch viele Jahre in diesem Sinne weitermachen kann.
7 Sekunden. 3,
Der Max, das ist unwahrscheinlich, wie sich der jetzt entwickelt hat. Wir waren jetzt, haben zusammen schon 4 Fahrradtouren gemacht und hier konnte man nichts mehr feststellen, dass er da irgendwelche Probleme hätte.
Wir treffen uns am Sportgeländer und machen uns die Touren aus. Wir machen Mittagessen, unterhalten uns gemütlich über das oder über jenes. Das ist also eine sehr gesellschaftliche Angelegenheit. Ich fühle mich wieder verdammt wohl nach dieser OP. Ne? Ist einfach wunderbar.
Well, dear colleagues and friends, also a warm welcome from my side. After this heartbreaking video of this patient, I want to encourage you to take part in this discussion. The focus of this webinar today will be the discussion, so type your questions into the chat and we will try to answer these questions. And I want to start with a question to Mariana and Lyon. You have seen this patient suffering from loss of exercise capacity, shortness of breath, and you are a internationally renowned heart failure expert. Do you think these are typical symptoms of patients presenting with tricuspid disease?
Thank you, and hello everybody. Yes, it could be. This can be a typical presentation in an active patient, like the patient we have seen in the video. So in particular, loss of exercise capacity is quite common in this kind of patients. However, let's remind that other patients, less active patients, can present with different clinical signs and symptoms, more specific. So in general, the clinical presentation of tricuspid regurgitation strongly depends on the physical condition of the patient and on the stage of disease. So in a patient at the initial stage of disease, we can also have lack of symptoms if there is no severe tricuspid regurgitation and if there is no overload of the right chambers. Then if we have severe tricuspid regurgitation, we have an initial overload of the right chambers with symptoms that can be more or less specific. So we can also have, for example, abdominal distension, dyspepsia due to the visceral congestion without dyspnea. And also, even more importantly, probably is the need for low doses of diuretics with a good response to these therapies. Then, of course, in the later stages, we can have typical signs and symptoms of right heart failure like hepatomegaly, jugular vein distension, peripheral edema, and the need for higher doses of diuretic, of course. And in the end stage phases, we can have also ascites, pleural effusion, and diuretic resistance. So, of course, in the later stages, the identification of these patients is easier because often they need an hospitalization. In the early stage, it's sometimes more difficult to identify these patients because sometimes their symptoms and signs are specific and mild.
Marianne, you already told us a little bit about the medical therapy of those patients. Of course, we do have guideline-recommended medications for left-sided heart failure, But do we have any guideline recommendations also for the medical therapy in patients with right-sided heart failure?
Let's say that unfortunately we don't have specific medical therapies for chronic right heart failure. We have specific recommendations for acute right heart failure, isolated acute right heart failure in our 2021 heart failure guidelines. But these recommendations are basically regarding the volume overload. So we can use diuretics to optimize the volume status to reach a euvolemic condition. And then if there is resistance to the diuretics, we can use IV combinations of diuretics. And if there is a hypoperfusion, we can use inotropic drug and vasopressor and so on. The problem is that in patients with chronic right heart failure, we don't have specific drugs beyond diuretics. But let's remind that in front of a patient with tricuspid regurgitation, we have to, first of all, identify the cause of tricuspid regurgitation, because treating the cause of tricuspid regurgitation, in some cases, we can improve tricuspid regurgitation. So this is very important to identify the pathophysiological mechanisms behind our right heart failure. And for example, if we have HFrEF, we have to use our 4 pillars and CRT as indicated in the guidelines. If we have a pulmonary disorder, we have to treat the primary pulmonary hypertension with specific drugs if indicated. If we have a pacemaker lead interfering with the tricuspid leaflets, we can, in selected cases, consider a lead extraction, for example. So first of all, consider the primary cause, treat the primary cause in addition to the diuretic therapies for decongestion. And this is the general recommendation, let's say. Then, of course, we don't have specific drugs for isolated right heart failure and for tricuspid regurgitation.
Well, so the diuretics are the cornerstone of our right-sided heart failure therapy. Nina, do you think many patients complain about side effects of diuretics? Do you think that compliance to diuretics is a problem in these patients?
Well, to my personal experience, I would say yes, because so patients want to live their daily life. So if they take diuretics in the morning, that might be still fine, but then they have to take another dosage at midday, and they're not able to leave the house. So this is something which really limits the lives of the patient. So many patients should be on a certain dose of diuretics, but at the end, many of the patients will not take the dosage which would be appropriate for this stage of heart failure.
That brings me to the next question, Nicole. We already have heard that that tricuspid regurgitation is associated with malfunction of other organs. What kind of organ dysfunction should we look for, and how do we monitor these organ dysfunctions? Do you have any ideas?
Yeah, sure. So we have all the signs that are related to the right heart failure, but also to the increased venous pressure in those patients. So we have an impact on the renal function and the hepatic function. So we have to keep an eye on the GFR and on the enzymes of the hepatic enzymes. And this is something that we should monitor, especially in case of changes in in the symptoms of the patients. Most of those patients have several comorbidities, and sometimes it's very difficult to just catch this moment when it's time to go for something more interventional. And it's important to keep an eye on the blood test. BNP level is also important to catch, because some of those patients have pulmonary problems, and if we don't look at the BNP, then we might miss an increase in the symptoms due to the heart itself.
Perhaps, Mariana, most patients are on a stable situation for a long time, but then they're deteriorating. When is the best time when those patients should be referred to like a heart valve center for further examination?
It's a difficult question, difficult answer. I mean, we don't have strong evidence regarding the optimal timing for treating tricuspid regurgitation, but we know that if we treat tricuspid regurgitation at the late stages, we have a poorer outcome in these patients. So it's the ideal timing is probably to refer patients at an early stage when we have a severe tricuspid regurgitation, but a mild overload of the right ventricle and the mild symptoms, as we have described earlier. Now, a particular condition that should lead to refer the patient to a heart valve center, I think, is the need for an escalation of diuretic therapies, of oral diuretic therapies. This is very important because if the patient need a higher doses, a higher dose of a diuretic, like from 20 milligrams to 40 milligrams, and then he feels fine. This is an important sign to consider, because this can be considered a worsening heart failure event in according to the recent novel definition of worsening heart failure. And this should lead to refer the patient to an heart valve center for further evaluation and the possible intervention.
Mariana, I have a very interesting question from the chat. What diuretic should we use, and what combinations would you refer?
It depends. I mean, generally, the combination of diuretics is indicated in case of resistance to diuretic therapy. So the first line diuretic therapy is generally furosemide or toracemide. Then, if there is no diuretic response to this drug, we can use, for example, acetazolamide. We have recent data showing an efficacy of this therapy in improving the congestion of heart failure patients. But we don't have, to be honest, specific evidence for right heart failure. But in the clinical practice, we use combination of diuretics when there is diuretic resistance.
I think this was an excellent summary to answer these questions.
Nicole, perhaps now you're also working in a very important heart valve center, and you often see patients being referred at very late stages of the right heart failure. Mm-hmm. Working together with many general cardiologists here in Paris and in France, what is your recommendation on when to refer a patient?
Well, actually, I think that there should be an initial referral. Of course, I'm not talking about a mild tricuspid regurgitation, but as soon as we see that we are getting inside a tricuspid disease, it's important for me, at least, to have a first referral to the heart valve unit, which doesn't necessarily mean that we'll go for a treatment, but at least we will understand who is this patient. As Mariana said, is there something that is leading or creating this tricuspid regurgitation? So maybe all the way etiologic workup has to be done. So I guess the sooner the patient is referred, the better it is. Even it doesn't mean, again, that we'll go for invasive treatment.
Any additional recommendation from your experience working together with a lot of cardiologists in the field in Germany?
So I think it's not that easy, because Mariana pointed out very nicely that patients with tricuspid regurgitation have symptoms in the later stages. And even at a severe stage, when tricuspid regurgitation is already severe, some of the patients don't even have real symptoms. So the symptoms come in many of the patients later than the severe status. So if a patient, if you see a patient and the patient has symptoms, this patient is usually in a stage where tricuspid regurgitation is already severe. And when the patient comes with symptoms, I would say, yes, this is a time point to refer the patient and to think about the general and conceptual design of his treatment.
But isn't it the case that most patients are only then being sent if they had a heart failure hospitalization, At least this is what I'm experiencing in my hospital. So we're really too late. Don't you think so?
Yeah, I mean, this is something we also see in the studies. The patients we are treating are in the very late stages at the moment. So yeah, that's why I would like to point out that a patient with symptoms, yeah, we really have to address it. We have to look at tricuspid regurgitation. We have to look at the kidney and the liver function. We have to evaluate this patient, and we have to develop a concept for the further treatment of the patient.
And you as an imaging expert, we were talking a lot about symptoms and referral when the patient is decompensated. What can you share with us an idea how to assess quickly and maybe easily the severity of tricuspid regurgitation with echo?
Yeah, we just have to understand, I think, that a decompensated patient is a completely different patient than a patient who is compensated. So a quick evaluation, I would say, if you just do an echo and you want a first glance, a very quick evaluation is the color jet. I mean, the color jet is not really good for the quantification of tricuspid regurgitation, but it really reveals very quickly if there is tricuspid regurgitation. And if you have the impression there is a large jet, then you can assume we have relevant tricuspid regurgitation behind. Another parameter which worked out to be fairly good to differentiate between at least moderate and severe tricuspid regurgitation is the vena contractor biplane. So if you just look at the vena contractor and you have a value of more than 7, so this indicates at a first glance that this patient has severe tricuspid regurgitation.
Now we're learning that there are these additional grades of severity. So beyond severe, we have massive, we have torrential tricuspid regurgitation. Is this useful for the clinical practitioner in daily practice, or is this more for the research and for all our clinical studies which we are performing?
I think it's maybe not that much important for the general practitioner because if you see a patient outside of the hospital, so the decision you have to make is if this patient needs further treatment. So, and if severe tricuspid regurgitation is the indicator to think about further treatment, I think this is not that important. But what we know already is that a patient with severe or massive or torrential tricuspid regurgitation, so these patients are not the same because the patients with a further stage or more severe tricuspid regurgitation. So these patients have a worse prognosis. And it's not even, so Mariana already pointed that out, it's not only that the patient, if the native course of the tricuspid regurgitation is worse, it's not only the case. Also when we treat the patient at the torrential stage has a worse outcome than a patient on a severe stage of tricuspid regurgitation.
And here's a question from Elisa Liss from the chat, which was designed for you. At which phase of the heart cycle should be tricuspid annulus measured on echo and four-chamber view, systolic or diastolic?
So which parameter?
Annulus.
Annulus diameter?
Okay, this is an interesting question because this is really advanced. So I do both actually, and I don't measure it in a four-chamber view. So I usually do a 3D analysis. And I look usually for the largest dimensions. So if I would do it in a four-chamber, you have to be really precise because if you have a tilted view, you get completely different measurements. So you have to really precise with your four-chamber. And I usually go for the largest diameter, and I measure in diastole and in systole.
And another question that goes more or less to all of us, maybe Nicole can start. Patients with torrential regurgitation diuretic treatment, which became then moderate to severe. Should we treat those patients?
Oh, this is not an easy question, but I mean, those patients are severe anyway. If we code them at some point being torrential, then probably they already have some symptoms, they already have some advanced disease. So most likely, yes, it's very difficult to answer at this point. But I guess, yes, those patients should be at least, again, referred for further analysis and to see where is it coming from and whether we should start planning something.
But this brings us precisely back to the question when the patient is being hospitalized for heart failure decompensation. Should we assess the patient then, or should the patient be in a euvolemic state, as you indicated, Mariana? Do you have any idea, or how would you target this question? More in the euvolemic state, or when the patient is decompensated?
Of course, in a euvolemic status. We know that tricuspid regurgitation is strongly dependent on from the overload, from the cardiac overload. So, of course, we have to optimize volume status before performing a comprehensive echocardiography for the evaluation of tricuspid valve anatomy and right ventricular function. It's quite common in patients hospitalized for acute decompensated right heart failure to have a huge improvement in tricuspid regurgitation after treatment, a reduction in coaptation gap, reduction in tricuspid annular dimension, reduction in right ventricular dimension too. So this is important because we can have a real perception of the condition of that patient, and also because this can be useful for the screening for procedure like the edge-to-edge procedure. But in coming back to the question, I fully agree with Nicole. That patient needs to be treated probably because it's a fluctuant tricuspid regurgitation, but even after treatment, we have a moderate to severe regurgitation, and this means that the patient need treatment for having a moderate severe tricuspid regurgitation, which is still severe. So I agree with Nicole for the treatment of that patient.
Thank you so much for this comprehensive answer. And Nina, what do you think? Many patients appear to remain stable after recompensation for years. Which parameter seems to be handsome to assess the progression of a tricuspid disease?
Yeah, not so easy, that question. So I think you have to differentiate what is the cause behind. I mean, if you have a left-sided problem, it's most likely that the left-sided disease, for example, aortic stenosis or mitral regurgitation, which are the most frequent ones, that they drive the progression of tricuspid regurgitation. It's much more difficult if you address the patients with isolated tricuspid regurgitation. And if you look into data, these are different parameters which show us that the patient might be under at risk of progression. This is, for example, if you have female patients, the age of the patient plays a role. Parameter like Nicole already pointed out. So we have liver enzymes which are elevated. We have right ventricular dilation, or we have pulmonary hypertension. So these are comorbidities and clinical parameters which more likely can predict that the patient will have a progression of his tricuspid regurgitation.
So if you see your patients on a regular basis, let's say he's coming back every half year or every other year, and you see a progression in these chamber sizes, when do you think is the time to look into this in more detail? When to send the patient into a heart valve center? When do we need to get active?
Yeah, I mean, I think we come back to the main question, does the patient have symptoms? I mean, if the patient has an enlargement of the right ventricle, it's clearly a sign that we have some amount of progression of the disease and that we should have a close look at the patient. If tricuspid regurgitation at this moment is still in a moderate phase, I would observe the patient, but would like to see the patient earlier. But as soon as the patient becomes symptoms and the degree of tricuspid regurgitation is going to be progressive, then I would definitely think about referring the patient to a heart valve center.
We have some questions regarding the interventional strategy. I think we handle those later. Maybe another question for you, Nina. Any tips to better characterize and evaluate tricuspid regurgitation in patients with mitral or aortic prosthesis, which may give echocardiographic shadowing?
Yeah, as a shadowing is a big topic. So what you can always try, if you don't have a chance to see something, there are some modified chamber views which you can use. For example, if you have a peristomal long axis and you tilt the probe a little. So in many of the cases, because in this view you usually don't have the shadowing of the mitral valve, but in many of the cases you need non-standardized views. So this would be one of those. Another one which could be helpful if you are in a two-chamber view, in a transthoracic two-chamber view and you tilt the probe a little towards the aorta, this is also a view which can be used. And in many of the patients, you have a pretty good subcostal view where you can address the tricuspid valve and you can get a long axis and a short axis view. So this can be helpful to have a look at least at the tricuspid regurgitation.
Maybe, Nicole, you studied in great detail the right ventricle, the dilatation, but also especially the function. What kind of parameters can we assess and what makes sense in the presence of tricuspid regurgitation?
Well, I'm not sure that there's only one parameter. If I only have one answer to give, it would be RV-PI coupling, but I'm not even sure. I guess we need more than one parameter. Obviously, what we see with our referring physician or people who are not really into the tricuspid domain, we will always see a TAPSE in the report. And it's very important to know that it's not a reliable variable. Most of those patients already have cardiac surgery. Their longitudinal function might be altered, but their circumferential function is okay. So it's important not to rely solely on TAPSE. RV the fractional area could be measured. The RVEF. We also have a role for CT and MRI in this situation. And one important parameter is the relationship between RV and PA. An RV that is working with a low pulmonary artery pressure is not the same as an RV working with a high pulmonary artery pressure. It's very important to do the ratio between, if we are using TAPSE and SPAP, but not only relying on simply TAPSE.
I think we answered already some of the questions regarding right ventricular dysfunction. And this is an interesting question. Which level of right ventricular dysfunction and which measure parameters would advise against any intervention?
Very difficult to answer again, because those patients, I mean, if we look at our regular practice, we see that those patients, when we treat them, they don't do as well as patients who have a normal RV function. But the question remains, will they do worse after a tricuspid repair than without a tricuspid repair? This answer, we don't have it. We never randomized in patients with severe RV dysfunction treatment versus no treatment, and we will never do it. Most likely, they're not in those studies. But I'm not sure that what would be the cutoff. So, very difficult.
Maybe one quick answer to this probably very difficult question. When there are mitral and tricuspid regurgitation in a patient with atrial fibrillation, and mitral regurg is maximum moderate, and tricuspid more than severe, would you treat only tricuspid or first tricuspid?
I mean, difficult without seeing the echo, as you said. But the only thing is that by repairing the tricuspid regurgitation, sometimes you see that mitral regurgitation is actually increasing. And there's a danger in just treating the tricuspid regurgitation and leaving the mitral regurgitation, that you will have to take the patient back very quickly. I guess you've seen that in your experience. Maybe I can revert the question. But yeah, I wouldn't just treat the tricuspid and leave the mitral if it's moderate or more.
Now, you already told us about the importance about the coupling of the pulmonary pressure to the right ventricle, or other way around. Now, we have all the difficulties in assessing pulmonary hypertension by echocardiography. Why is this the case, Nina?
Well, actually, Nicole pointed out the major points. So I'm not sure if I can show you, but this is very impressive, I think. I'll try it.
If we have the one slide.
So if you have one slide that we can show, and if you can keep it running, this would be wonderful. As you can see, so this is a tricuspid regurgitation and a very enlarged right ventricle at the end stage. So we hope they can make it running, okay, especially the one on the right-hand side. And this is a 3D volume. And as you can see, if you look at this bizarre contraction of the right ventricle, this is definitely not a right ventricle which contracts in the longitudinal axis. So in the later stages of the disease, so it's more likely that we have a radial contraction which is more pronounced, and it's not even equalized and balanced, because you can see that there are some regions where contraction is better than other regions. So this is why I would say conventional parameters like the TAPSE are not really good for indicating right ventricular function in these cases. Actually, we have poor data which could tell us what is the right ventricular function which works. I mean, Jörg, you already did some work on this space. And so what we know, at least, if you look with 3D volumes on the right ventricular function and the ejection fraction, we get some ideas. And this can be done by MRI, or this can be done with 3D echo. And a value around 45% indicates that these patients will have a worse prognosis. And another parameter which could be useful, especially in patients who are asymptomatic, is that you use a free wall strain of the right ventricle. So these are some indicators which could tell you very early that the right ventricular function is going to be deteriorated.
So we need much more complicated echocardiographic measures to really assess the right ventricle. Everybody is always talking about MRI as the gold standard. Mariana, do you use such additional techniques often in your daily practice? CT, MRI?
To be honest, I don't use routinely the MRI and CT because, as nicely showed by Nina, the echocardiography performed by an expert operator can give us a lot of data and information regarding the right ventricle and the tricuspid valve. I generally use MRI when I have a right ventricular dysfunction and when I have excluded all the possible causes. And so I want to make sure that there is no primary right ventricular disease. And I perform CT when I have a patient with an indication to intervention and to transcatheter intervention, and the edge-to-edge procedure cannot be performed because of because not anatomically suitable. So I perform a CT to look at the criteria for a replacement. These are the two conditions when I use a CT and MRI.
Nina, maybe a question regarding what you just told right now. Can you name a cutoff value for right ventricular strain where you can say you can expect worsening of right ventricular function?
Yeah, I mean, so we just look at the normal values, and if it's going below 80% of the free wall, this gives you an indication that there should be some deterioration of the right ventricle.
And maybe another question regarding the assessment of tricuspid regurgitation. When evaluating a patient for an edge-to-edge repair treatment, do you think we should focus more on the absolute coaptation gap or on the addressable gap, such as, for example, in the end-receptal zone?
Well, I think it's a combination. So if we assume that the patient is in a compensated status, yeah, the gap size plays a role. But there's some tips, and Jörg, you can maybe add something to that. There are some tricks if the patient is on the table, what you can do to minimize the gap size. So all the points have to come together. I think the gap size where the jet originates is important because we know that we have the best results if we have a jet which originates from the anteroseptal or from the central part, and it's getting more difficult if we have to go to the posterior part, and it's getting even more difficult if we have an involvement of the anterior posterior commissure. So the origination of the jet is definitely a very important parameter. Gap size is important because if you use an edge-to-edge device, you have to make sure that you can overcome and to bridge the gap. So, but there are some things you can do in the cath lab, and Jörg, maybe you want to comment on that. I mean, you have been involved in some studies, so.
No, absolutely. I think there are 2 or 3 aspects which come into place beyond putting the patient into a euvolemic compensated status. Most sites currently prepare the patients, so they release the patients, especially before the procedure, so that the patient are not well hydrated, so the volume is smaller, and also the gap size of the right ventricle and between the leaflets is getting smaller. Then in the procedure, there are 2 additional techniques which we could use for making the gap smaller, which is either the inverse Trendelenburg position, so you put the head high and the feet low, so all the volume is in the feet, which also brings down the leaflets, makes them easier to grasp. And you can also increase the expiratory pressure in the ventilation, which also reduces the backflow of the blood to the heart, reducing again the gap size. So there are many techniques which we can assess, but these are more really than techniques for in the procedure to really maximize the outcomes. But assessing tricuspid gap sizes, as we just heard, also always probably, do we need transesophageal echo for that, or can we do this by transgastric imaging or transthoracic imaging? How do you do this in your practice?
I would say I always do a transthoracic before, and in some patients with a really good imaging quality, you can get really nice 3D images, and then it's possible. But you need a short axis view, I think, because you really need to measure the gap at the site where you want to place your device. So you need a short axis view. So if this is doable in a good quality from a transthoracic, you can look at the gap in a transthoracic view. But if I consider a patient for an intervention, I always do a TE because I get some additional information, sometimes a better view of the tricuspid valve, and I can get a transgastric view. And in the transgastric view, it's usually easiest to measure the gap exactly at the site where you want to place your devices during the intervention.
And I think we have a very, very good and excellent question from the chat. I hand over to Nicole because we can work out the relevance of hemodynamics in tricuspid disease. The question is, but TAPSE is not reliable in more than severe TR, neither pulmonary artery pressure systolic, derived from the echo because of velocities equalization. Still, we use PR RV coupling using both parameters which are not reliable. I think what you said recently points out that we need invasive hemodynamics. Is it like this?
Absolutely. So when we are talking about SPAP, if we don't have any choice, and this is what we have on hand, we will have to use the SPAP that we have on echo, but we know that it's imperfect. The ideal is to have a right heart cath in every patient that we have. It's not only to assess the pulmonary artery pressure, we need to have an invasive pulmonary artery pressure to know exactly what's the pulmonary artery pressure in our patient. We also need to understand what kind of pulmonary artery pressure we are dealing with. Is it a pre-cap? Is it a post-cap? And it makes a lot of difference in the decision-making regarding the treatment of tricuspid regurgitation. So it's important to have a right heart cath, and of course the question is very accurate. If we can have an RV coupling based on a right heart cath, this is what we need to have.
So you're already talking about right heart cath. What kind of parameters do we really need to assess in the right heart cath, which are leading us to the right decision making?
So again, there's the SPAP. We have to understand if it's pre or post cap. So we will have to look at the transpulmonary gradient. We also want, as we said, we want to see our patient in an euvolemic state. So we have to look at the pressure in the in the right atrium. If we have a very high right atrial pressure, we also have to look at the V wave. But if we have a very high right atrial pressure, then most likely our patient is not still euvolemic, and maybe we will have to work to give more diuretics before going to TE and saying my patient has a very large gap. So we have like V wave, right artery pressure, transpulmonary gradient, pulmonary artery pressure.
Cardiac output?
Cardiac output, of course. Yeah, sure. Absolutely.
Marianne, do you also perform right heart cath in your practice in Italy?
Yeah, of course. In all patients with severe tricuspid regurgitation, is a paramount exam to do a comprehensive evaluation of our patient. As already said, we need to assess pulmonary pressures, but also cardiac output. There is an interesting studies showing that intermediate values of cardiac output are related to the better outcome, whereas high values and low values are related to a poorer outcome in patients undergoing transcatheter tricuspid valve intervention. And this is probably related to the fact that higher cardiac output may be related to the hyperdynamics in patients with liver dysfunction, and low cardiac output are of course related with a poorer outcome because of hypoperfusion. So it's interesting to put together all the information in order to reach the better diagnosis, the better treatment for our patients.
Wonderful. Maybe I'm coming back to you, Nicole. We already discussed about the assessment of the pulmonary artery pressures and the precapillary and postcapillary pulmonary hypertensions. Is pulmonary hypertension a contraindication for interventional tricuspid valve repair?
So again, it's very close to the question that I had previously regarding the cutoff for right ventricular function. Again, those patients, we don't know. We know that they do worse than patients without elevated pulmonary artery pressure, but are we doing them any harm, or aren't we bringing them an improvement in quality of life by treating tricuspid regurgitation? I'm not sure. What's sure, and that what you proved, is that there's a difference between pre and post capillary. Of course, if there's a patient coming with a severe pulmonary disease with a precapillary pulmonary hypertension, I'm not sure that treating the tricuspid will improve his symptoms. While if he comes with a post capillary pressure with low resistance, it's most likely that probably we can improve his quality of life. So there's a difference between pre and post, but nobody can give a cutoff at this point. I don't know what you're using in your practice.
But we're also doing a right heart cath, as you said. With the postcapillary pulmonary hypertension, I'm not really worrying a lot about the patients and the further course. Precapillary, as you just said, is something completely different, and these patients need to be well prepared on their medications for their pulmonary disease usually, and if they still have some disease, we discuss it on a very individual basis with the patient, see the expectations, and see if we can then find a decision for or against such a therapy. But this brings me to another question, which we always hear, and which was always our fear in the past, is when we have patients with reduced RV function, still having an elevated pulmonary artery pressure, and then we're closing the valve, that the patient will suffer an acute right heart failure. Is this something you're going to observe in your practice, Nina?
I mean, I think if we do an edge-to-edge approach, to be honest and to be realistic, in most of the patients, you don't come to a TR grade, which is 0. Yeah, and we don't really close the valve. So the tricuspid valve is usually a large valve, and we usually don't create significant tricuspid stenosis. So in my career or in my experience, I've never seen a relevant tricuspid stenosis in these patients. So this might be the case if you have a patient with rheumatic valve disease, which involves the tricuspid valve. So this is a different kind of story. But if you look at the native tricuspid valve with a dilation of the annulus or even a tethering of the tricuspid valve, and the rings are large, the annuli are large, so in most of the cases you don't create a relevant and significant tricuspid stenosis.
And the worries, Nicole, about afterload mismatch and acute right heart failure after the procedure, is this a problem?
We've seen some of that after the procedures. Maybe the problem rises more with replacement than with repair. As Nina said, we always have some residual TR after an edge-to-edge repair, while with replacement, it will be a more serious problem. We've seen some of the events, most likely you've seen more than me because you've done more replacements, but I'm not aware of death regarding to that. Maybe it's a difficult time to pass. I don't know if you've seen any real lethal heart failure after this procedure. Maybe you have to more help the patient in this phase if he has a severe right ventricular dysfunction.
But I think it's very important to highlight that these procedures are very, very safe. Although our patients are very, very fragile on the other hand.
Absolutely.
So this is, I think, something we need to really realize on a daily basis again and again, that we can treat many patients and we're usually not doing any harm.
But I think we can say that what we learn from surgical procedures after tricuspid interventions or surgical interventions, that we are afraid of a right heart failure, is something that we rarely or never see in interventional approaches. And I think this might have to do with the surgical procedure itself and opening the pericardium. So I think this is something that we must learn new with interventional approaches. Mariana, maybe one question from the audience to you. Do we intervene in patients with moderate atrial TR whose diuretics were escalated maximally, and now mild new worsening of renal failure. So when we are at the edge of the renal function and we have a moderate TR, which is moderate because of the maximum escalated diuretics.
It's a strange situation, but I mean, probably, but it's important because we have to point it out that we have to reach a euvolemic status. So an overload is not good for the assessment of DR, but also an hypovolemic status is not an ideal condition to assess TR. So probably that patient is a patient in an hypovolemic status with a renal dysfunction, probably due also to the hypovolemic status with a moderate tricuspid regurgitation due to a hypovolemic status. So in that cases, I would reconsider the volume condition, maybe with the right heart catheterization in order to check the volume condition and maybe optimize a bit more the volume status. I think, and I think in a euvolemic condition, a patient like this would have a severe or moderate to severe tricuspid regurgitation.
I think this question raises the need, what is already written in the guidelines, that we need assessment in a comprehensive heart team, including a heart failure specialist and maybe also a nephrologist. But Nicole, maybe a question that arises during our webinar. Can you shortly summarize what interventional options we have currently available for patients with tricuspid disease?
Sure. So the first intervention is no intervention and diuretics, but this shouldn't be kept for a long time and not bring the patient in a hypovolemic state to us, pretending that he's not having any tricuspid regurgitation. But the interventions that we have the surgery, of course, and we have all that is percutaneous. And percutaneous, we will have the repair, including edge-to-edge and annuloplasty, and we will have the replacement. So far as CE marked, we just have had a week ago a replacement device that is CE marked. We have been dealing mainly with repair, and edge-to-edge has been the most performed procedure so far.
Now, of course, we have different phenotypes of tricuspid regurgitation. We know the more ages, secondary tricuspid regurgitation and the more the ventricle form of tricuspid regurgitation. Do you have any technology working better for the one or the other?
There has been no head-to-head comparison between the two. If you think about the pathophysiology and if you look at the valve, then you can imagine that one would do better. I will ask you to answer this question.
Well, the question is with the septal, with this very severe tethered leaflets, is an annuloplasty device working in such a condition very effectively?
I'm not sure.
Nina,
No.
you're doing some cardiovans, so you're the expert.
I have some experience, and to be honest, I mean, the easiest treatable patient is a patient with an atrial functional tricuspid regurgitation and an enlarged annulus, and no or mild tethering.
And no gap.
Yeah, okay, we can have a gap. No, a gap is nice. But to be honest, this is a perfect patient for each of the technologies. So you can easily imagine if you have a patient with severe tethering, and you just bring the ring together, you don't do anything for the coaptation gap. So it doesn't make a lot of sense to put an annuloplasty device in a patient with severe tethering. If it's mild tethering in addition to annuloplasty, yes, I would say this is an option for this patient, but not if you have severe tethering.
And then you would probably go for either edge-to-edge or
Yeah,
valve
I mean,
replacement
if the patient has a big gap, something you can consider is to implant, to do an annuloplasty and to make the ring or the annulus a little bit smaller and go for an edge-to-edge procedure and a second procedure. So this is something which is reasonable, or you have to think about another option like replacement. Now we have at least one device available, as Nicole already mentioned, or in a very late stage, if no other option, you can also think about a cable implantation.
Nicole, we already talked about a heart team and discussing such difficult patients. Who is part of your heart team in Paris?
Oh, it's very wide. It's very wide, and we will have to have one more specialist according to the patients that we have. So, of course, we have the imaging specialist, the interventionist, the surgeon, and the heart failure specialist. That's the basic. We will also have the nephrologist, and it's very important to have the nephrologists on board because sometimes they have the tricuspid regurgitation. They are treating those patients, but they don't know. So it's important to have them, but it's also important to have them to try to make this balance between volemia and renal function. Sometimes we will need the pneumologist to be on board because, again, if it's pulmonary hypertension, we don't know if we need to start a treatment for it before or what's the part of responsibility of the lungs in the story. Anesthesiologists are very important, and it's important for them to understand the procedure and know what we are dealing with. They can really be helpful during the procedure for reducing the venous return and help us to doing an edge-to-edge, for example. So, and we have the geriatricians, of course.
Mariana, there's coming one question which might be something good for you. There are some scores assessing, of course, surgical risk, but also outcomes in patients with tricuspid regurgitation. Do you use those scores and models in your heart team before you're going to decide if the patient is suitable for transcatheter therapy?
Yeah, of course. The most used score is the tri-score in our center, especially in patients with isolated tricuspid regurgitation. It's very useful to predict the risk of surgery at 30 days after the hypothetical intervention. And generally, patients with more than 4 or 5 of a tri-score are at increased risk for surgery, so they can undergo to transcatheter therapies. But I would like to point it out that all the variables included in the tri-score, for example, are variables related to the heart failure. So we have diuretic doses, we have right ventricular dysfunction, we have left ventricular ejection fraction, we have sign of right heart failure. So all these conditions, all these parameters are extremely important to be evaluated in these patients before considering any kind of treatment, medical therapies, transcatheter therapies, or surgical therapies. So needed to be considered in the heart team discussion to reach a decision.
Maybe a question regarding the TRI score from the chat. TRI score uses the item furosemide more than 125 milligrams, but each pill is 40 milligrams. And besides, most are under a combination of diuretics. Any thoughts?
No, it's depend on the country because, for example, in Italy, the one pill is 25 milligrams. So I think it's depend on the country, and also we have a pill of 250 milligrams. So an half of pill is 125. So I think it's depend on the countries.
Perfect. Now we need to come to the most important question about our interventional strategies and what kind of evidence do we have for that. Nicole, how much evidence do we have today to support an interventional treatment?
We have so much. No, as you know, this year we had the first studies, randomized studies. There has been none in surgery, and now we have 2 studies in percutaneous treatment. So the level of evidence for tricuspid treatment, whatever it is, remains low. But we had good news with the studies this year were positive. If we look at Reluminate, there was a positive endpoint. It was a positive study. We were a little disappointed because it was mainly driven by the improvement of quality of life, and we were questioning whether this KCCQ was enough to say that this is really not a placebo effect. And what we've seen at TCT 2 weeks ago with the analysis by Susanna is that in reality, KCCQ does reflect a prognostic factor, is a prognostic factor in patients with tricuspid regurgitation. So I guess we have enough data today to say that we are at least improving the quality of life of the patients. And we have other randomized studies that are coming over. We have TRIFR that is over and we are waiting for the results to demonstrate a potential reduction in mortality. What we've also seen in our registries, like the 3-valve or other studies, is that we have a reduction in terms of hospital admissions, in terms of diuretic dose, but on the long run, because we shouldn't decrease the dosage immediately, and we have an improvement in quality of life again.
Now, when you talk about quality of life and you consent your patient for a procedure, what are the expectations from the patient? Is it quality of life improvement? Do they want to live longer? What is for them the most important thing?
I mean, if the patient can have both, he would be happy. But if we tell the patient, I'm giving you, I mean, the main thing we've learned this year also from the studies is the safety of the procedures. So if you tell your patient that I'm going to perform a procedure that is safe and I will improve your quality of life, of course, the patient is willing to take that. We've talked about how much they want to get rid of their diuretics. We talked about their symptoms. So if you tell to the patient it's safe and it works, then they will want it, even if it's not improving their life, their mortality.
Well, thank you very much for this answer. And there are upcoming a lot of questions, and we really love this interactive session, but we need to come to an end. We have just some seconds left. I want to say thank you very much to the audience. I want to say thank you very much to the panel who made it through stormy weather here to Paris. What we learned today is that we have just a few medical options treating patients with tricuspid regurgitation and right heart failure, that it needs a comprehensive assessment, including hemodynamics, to see whether a patient might benefit from an intervention or not, or if he might benefit from assessment and treatment of pulmonary hypertension. And what we learned and what we are hoping for the future for these patients is that there is a bundle of interventional therapies coming up to treat these patients in the future, and it will be an interesting journey to see how we can help and treat our patients. Thank you very much and have a great evening.